Hi, so I was in the Bergen OR yesterday and it was an amazing day. I observed an entire procedure which involved polycystic ovary syndrome and endometriosis. I then later observed the beginning of a craniotomy. I was unable to stay for the drilling into the skull, but I saw the skull after the surgeon had made an incision in the scalp and separated it with the Rainey clips to expose the skull. The pre-op nurse's main goals are to educate, advocate, provide emotional support to patient and family, and to ensure that all assessments, pre-op labs and tests, and physical surgery prep are done. The inter-op nurse's main goals are to ensure the patient's positioning is safe to prevent any excess pain or injury, to start extra IVs if needed, and to prep the patient's skin and surgical sites. PACU nurses ensure that the patient's pulmonary and cardiac function return to baseline, ensure that vitals remain stable by taking them frequently, perform focused assessments, and provide pain control as needed. The nurse that I followed for the day was an intra-op nurse as well as a circulating nurse. She was incredibly knowledgeable and amazing in performing all of her duties. She had a friendly, positive attitude, but was also very professional and serious when needed. She performed the intra-op nurse responsibilities, plus managed the conditions of the OR. She initiated and ran the timeout. She charted every person that came and went from the room, plus every single thing that happened during the procedure. She was in charge of positioning the patient before the procedure began, and she also put all samples in cups and labeled them throughout the procedure. This is definitely an area of nursing that I would consider working in. It was exciting, fascinating, and held many responsibilities that interest me. The nurse protects the patient in numerous ways during the procedure. It ranges from protecting the sterile field to prepping the patient's skin with an antimicrobial solution to positioning the patient's body before, during, and after the procedure. One policy that I learned is that when the patient is in the Trendelenburg position for 4 hours and the procedure isn't over yet, he or she needs to be returned to supine position at 0 degrees for a period of time and then can be returned to Trendelenburg for the procedure to continue. Another policy is every time that the OR team announces they are going to reposition the patient, the anesthetist must immediately hold the ventilator tube in place. The circulation nurse is who initiated the timeout in my first procedure, and the surgeon did in the second. The RN stated the patient's name and the procedure. She didn't need to mention the correct site in this case because the site was the uterus, ovaries, and surrounding tissues and organs. The RN listed the patient's allergies and how she was prepped. She listed the meds that she had already been administered. At one point, she had to interrupt herself to tell an anesthetist medical student to stop moving around during the timeout. The differences in the second timeout was the neurosurgeon had everyone in the room introduce themselves, and he was the one who said what the procedure was. Again, since it was a craniotomy, he didn't have to mention the surgical site. As far as I could tell, the patient's privacy was protected and respected at all times. I believe the RN and the surgical tech advocated for the patient, and then they repositioned her a number of times before the procedure began because they were unhappy with her positioning. They finally decided to wait for the surgeon to finish so the patient would be in optimal positioning for her own safety and for the procedure. A sponge count refers to counting all sponges that are on the surgical table before and after the procedure. This is to ensure that they end up with the same number at the end and none of them were left inside the patient. The surgical tech and the RN performed the count at both of the procedures that I observed. The RN told me that the surgical tech is under the RN's license, so the RN is ultimately responsible for a correct sponge count. They also counted needles, surgical scissors, and Q-tips. I didn't see a report given from pre-op to OR but I imagine it involves information on the patient, meds administered, family present, and patient's level of anxiety. I observed one transfer from OR to PACU. The OR RN reported to the PACU RN, giving her information about the patient and family present, the procedure, what meds the patient had received, and she showed the RN the incision sites. There are multiple nursing diagnoses that could apply to this procedure. 3 priority ones are risk for infection, risk for bleeding, and risk for aspiration. I learned a ton from this experience. Overall, I learned that the OR is an exciting area of nursing, and the support and teamwork among everyone working there makes all the difference in a good or bad day. It was a very positive environment. I loved seeing how the surgeon manipulated a robot to have more control and range of motion during a laparoscopic procedure. I also loved observing the teamwork and encouragement among the employees. And another amazing thing is that I was able to go to the trauma bay to observe EMTs bringing in a patient transferred from Council Bluffs and watch staff from every area work together quickly and efficiently. I cannot think of one thing that I didn't like about this experience. It was a phenomenal day.